Hello and welcome everybody. My name is Amy Forbes. I'm the training manager from the Northwest Mental Health Technology Transfer Center. I'd like to welcome you to today's webinar, The Syndemic of HIV, Sexually Transmitted Infections, and Behavioral Health Disorders with Tim Menza. Please know this webinar is being recorded. Also, a certificate of attendance will be emailed to those who registered and attended, and we are not able to offer CEUs at this time. Now I'm going to give a brief overview of our network and some important information before we get started. The MHTTC is a nationwide network supported by the Substance Abuse and Mental Health Service Administration, or SAMHSA. Our network includes 10 regional centers and a network coordinating office outside of Stanford University. Our Northwest MHTTC covers HHS Region 10, which you can see in the bright pink circle at the top of the screen. These states include Alaska, Idaho, Oregon, and Washington. Our goals at the Northwest MHTTC are to support mental health-related evidence-based practices, heighten awareness, knowledge, and skills of the behavioral health workforce, foster alliances and address diversity of training needs, and to share free publicly available training and technical assistance. Our areas of focus include evidence-based practices for psychosis, including CBTP and assertive community treatment, or ACT. We also provide training on a variety of other topics, which you can definitely check out on our website. On our website, you can register for free webinars or learning communities, watch a recorded webinar, take a free online course with healthy knowledge, sign up for our weekly newsletter, review our resource library, or listen to our podcast called Putting It Together. And now I'd like to introduce Lori, who will be sharing information about the AETC Mountain West.
Sure, thank you. So I'm Lori Sila. I'm the director of the Mountain West AIDS Education and Training Center, the Mountain West otherwise known as AETCs. The Mountain West AETC is part of a national network of AIDS education training centers that are funded by HRSA, the Health Resources Services Administration, and we cover the entire U.S. and its territories. There are 8 regional AETCs. We cover Region 10 and Region 8. That includes the states of Alaska, Colorado, Idaho, Montana, North Dakota, Oregon, South Dakota, Utah, Washington, and Wyoming. So we have about 40% of the U.S. landmass and about 25% of the population. The AETCs also have 3 national AETCs. There's a clinical consultation center at the UCSF that provides warm lines for a variety of HIV clinical and prevention topics. There is an AETC support center based at Rutgers, and then we also have the National HIV Curriculum, which is produced out of the University of Washington. What we do is deliver innovative education and training to improve access to care and quality of life for people who are living with or who are at increased risk of acquiring HIV. And we are essentially the training arm of the Ryan White program. And our goal is to shorten the time for delivery of evidence-based practices, to spread adoption of evolving practices for HIV care, and to assure that there is a workforce that is trained and knowledgeable about HIV and related conditions, and also how to provide inclusive trauma-informed care. Next slide. And so this is just an acknowledgement of our funding. That's actually an acknowledgement of the funding that we just had ending June 30th. And we're funded at about $2.9 million for the current fiscal year. Okay, and I think that's it for me.
Great, thank you, Lori. We're going to go over some housekeeping for today's webinar. We will be sending a link to the recording as well as the slides and your certificate of attendance within a couple of weeks after this event. So for communication during this event, please use the chat box to reach our staff if you need any assistance, or if you would just like to share respectful comments, greetings, and observations with everyone in attendance. We do ask that you please use the Q&A box to type your questions for our presenter. You can do this at any point throughout the presentation, and we will be monitoring the Q&A box to facilitate answering as many questions as possible at the end of the event. And also at the end of today's event, we will send out a link to our survey. Please know that your feedback is very important to the work that we do and the content that we provide. We are required by SAMHSA to conduct this survey, yet they do not have an official position on our content. And with that, I am very happy to welcome and introduce you all to our presenter, Tim Menza. He is an infectious disease specialist with advanced training and expertise in HIV, STI, and viral hepatitis prevention and care. Tim has extensive experience in creating, implementing, and evaluating public health policy and advocating for communities through the system level change. As medical director of Oregon's HIV, STD, TB program, Tim facilitated the implementation of a free statewide home HIV STI testing program, public health accountability metrics for the prevention of congenital syphilis, partnerships with correctional facilities to increase HIV, STI, and HCV testing, and led Oregon's response to Mpox. Tim is currently an associate professor in the Department of Medicine at the University of Washington and a medical director of the Sexual Health Clinic with Public Health Seattle and King County. So Tim, thank you so much for being here.
Thanks for having me.
I will stop sharing and hand things over to you.
All right, so hopefully you're seeing my slide deck. Thank you so much. Thanks for having me. And so let's get into what we're going to talk about today. So the agenda for this talk is going to start with reviewing the epidemiology of HIV and syphilis in the United States. We'll really focus on syphilis as our exemplar of STI here. And then we're going to spend most time discussing the syndemic connections between HIV, syphilis specifically, substance use, and behavioral health. We'll then move into reviewing HIV, syphilis, and hepatitis screening guidelines, and then explore how we can integrate HIV and STI prevention into behavioral health work. And then I also want to provide or let you all know that public health, your local public health agency, may be and can be a partner in this work. So I also just want to start off by kind of acknowledging the situation that we're sort of in, where we have this situation where we kind of have a lack of essential health and social and community services, but we've got a lot of need, a need that stems from trauma, from poverty, from housing instability, from feeling disconnected to our communities, to mass incarceration and community violence. Then thinking about the things we're going to talk about today, mental health and substance use, intoxication, overdose, hepatitis, HIV, syphilis, COVID-19. And these are kind of things that are really sort of symptoms of a larger wave, as the metaphor might go. So I just want to sort of start here saying that this is big, but it exists in a larger context here. And as such, as just a kind of a point of grounding, that screening, testing, and treating sexually transmitted infections is part of SAMHSA's whole person approach to behavioral health, treatment, and substance use prevention. Okay, so let's start with HIV, shall we? So 2019 seems like a long time ago, but in 2019, the United States set a goal for ending the HIV epidemic. And that goal was a 75% reduction in new HIV infections in 5 years. We're here, it's 2024, and a 90% reduction in 10 years. And the idea was that there were a couple different pillars, right? We're going to diagnose folks, we're going to treat folks as soon as possible with great medications. We're going to start folks on pre-exposure prophylaxis. We're going to do some cool epidemiologic work to identify growing clusters, and then we're going to build an HIV workforce. We're not on track to meet those goals. So here's what it kind of looks like over time. I'm kind of pulling us back to 2014, where we had about 40,000 new HIV infections. And in 2023, we had a little over 34,000. And overall, we've kind of made about a 12% decrease from 2019 to 2023. So 2024 is about over, so perhaps that 75% will come, but it's going to take a lot to do in less than a year. So let's kind of just round out sort of what's happening across the United States with HIV. And so 8 states account for over half of the new HIV infections in the United States. And those 8 states were California, they're the darker red, Florida, Georgia, Illinois, New York, North Carolina, Ohio, and Texas. And these states accounted for about 57% of the new HIV infections. And so if we look now just at sort of specific demographic groups, and we'll kind of step through these to look at kind of the progress we've made, because there has been some progress. So people assigned male at birth experienced a 12% reduction in new HIV diagnoses. So basically comparing this, what we're seeing here is people assigned male at birth, people assigned female at birth on the left and the right respectively, with 2018 in purple and 2022 in blue. And the decrease that's observed here is a 12% decrease in new cases of HIV, of new HIV diagnoses among people assigned male at birth. We haven't seen a change from 2018 to 2022 among people assigned female at birth. And in 2022, 81% of all new infections were among people assigned male at birth. Now, I'd like to, the CDC also has been more recently using sort of better measures of gender. And so while sex assigned at birth is helpful, gender can be even more helpful. And when we look by gender, people who identify as men and women, cisgender, their rates or cases have been stable. However, we've seen an increase in HIV diagnoses among transgender women and men and non-binary people in the United States with respect to HIV diagnoses. And then looking at age, people 13 to 24 years of age experienced a 30% reduction in new HIV diagnoses. And if we look at each of these age categories, really we only saw a decrease in this youngest age group, 13 to 24. And it represents a 30% reduction, and 13 to 24-year-olds in 2022, or I should say the largest group, the 25 to 34-year-old age group, represented the largest percentage of infections at 40%. And Black Americans experienced an 18% reduction in new diagnoses, again, comparing 2018 in the purple to 2022 in the blue. But 37% of all new HIV infections were among Black Americans in the United States. And we really haven't seen similar decreases. And if anything, we've seen sort of a bit of an uptick after maybe some years of decrease in Hispanic and Latino people. And racism continues to drive inequities in new HIV diagnoses in the United States. Here, what we're looking at is the percentage of new HIV cases that are represented among specific racial and ethnic groups, comparing that to the population in the United States that's represented by that racial and ethnic group. And what we can see is when there's a mismatch, when the red bar is longer or larger, has a greater percentage than the teal bar, there's an inequity. So among Black and African American and Hispanic Latino Americans, as well as among multiracial folks. Now, sort of for some of the smaller groups, the Native Hawaiian, Pacific Islander, American Indian, Alaska Native, even though those numbers are small, There are also documented inequities in states or jurisdictions where those populations are large. And then when we look at diagnoses by behavior, new HIV diagnoses among people assigned male at birth fell 10% among those who report sex with men. So again, looking all the way to the left-hand side, comparing the purple in 2018 and to the blue in 2022. There was also a large, but they put a little asterisk by it because it might not be statistically stable, decrease among both men, people assigned male at birth who report sex with men and also use injection drugs, and a decrease of about 27%. And in 2022, people assigned male at birth who reported sex with men accounted for 83% of new infections among men. And if we look at, if we intersect this with race, we see that there was a 16% decrease among Black men who have sex with men. So that also includes gay, bisexual, and other men who have sex with men, and a 20% decrease among white men who have sex with men. When we look at people assigned female at birth, also looking at behavior, we really don't see a change across the behaviors of injection drug use or heterosexual contact. And in 2022, HIV attributed to heterosexual contact accounted for 83% of new infections among people assigned female at birth. So that's the kind of accounting for HIV at this point, sort of the most up-to-date information from the CDC. I'm going to transition to syphilis. Syphilis is back. Data collection for syphilis began in 1941, and syphilis was made a notifiable condition shortly thereafter. There were some really steep declines initially that we see, which was really related to the advent of penicillin. However, from 2011 to 2022, the rates of total syphilis have basically increased every single year. And in 2022, we're going to break these down by a couple different categories, because syphilis, of course, has to be complicated and has stages. It has a primary and secondary stage, which is in blue here, both in the text and the chart here, the plot. And those are the early symptomatic stages of syphilis. The red is an early asymptomatic stage. So it's called early non-primary, non-secondary, formerly known as early latent. And then finally, there's syphilis of unknown duration, or late, formerly late latent, where it's an asymptomatic stage of syphilis, but folks just either don't know when they got it, or it's been around for about a year. And what we've been seeing is that we've been seeing increases in all of these stages. And so in 2022, we had 59,000 cases of primary and secondary syphilis, 56,000 cases of early non-primary, non-secondary syphilis, and close to 90,000 cases of unknown duration or late syphilis reported in the United States. And during this time, from 2021 to 2022, the rate of primary and secondary syphilis increased 9%. The rate of early non-primary, non-secondary increased 10%, and the rate of unknown duration or late syphilis increased about 30%. And so what we're also seeing is that in 2022, there was, now I'm adding this total syphilis number, there were a total of 207,000 cases of syphilis in total. And that total rate increased from 17% from 2021 to 2022. If we look back a little bit further to 2018, the total rate of syphilis increased by almost 80%, 77% to be exact. And here's the just those increases that I talked about from 2021 to 2022. So even in just 1 year, pretty significant increases. And then if we look back even further from 2018 to 2022, again, those increases are quite large, with an overall 77% increase in total rate of syphilis. And in 2022, the West had the highest rate of reported primary and secondary syphilis, with a 1.4% increase from 2021, followed by the South, then the Midwest, and the Northeast. And the Midwest actually had the greatest 5-year increase in rates of primary and secondary syphilis, with a 107% increase. So the Midwest has seen the largest increase in syphilis, whereas the rates of syphilis are highest in the West. And this is just kind of looking at a nationwide view. The rates of primary and secondary syphilis ranged by state from 0.5 cases per 100,000 population in Vermont to 84.3 cases per 100K population in South Dakota, with the dark blue kind of representing states with higher rates compared to sort of the yellow with states with lower rates. And just like we saw in HIV, racism also drives inequities in primary and secondary syphilis. And in 2022, the highest rate of reported primary and secondary syphilis cases per 100,000 persons was among American Indian or Alaska Native persons, with a rate of 67, followed by Black or African American persons at 44.4. And we saw that the increase among Indigenous folks in the United States from 2021 to 2022 was 44%. And if we look back 5 years, it was 335%. And during 2021 to 2022, the rate of reported primary and secondary syphilis among women increased 19%, while the rate increased among men 6%. And again, if we kind of step back those 5 years, and then even if we look back 10 years, in the last 5 years, focusing just on women here, an increase of 190%, and in the last 10 years, an increase of over 800%, almost 900%. And what we're seeing is that during the period from 2013 to 2022, here represented in this plot, this is now looking at the cases of primary and secondary syphilis by not only sex at birth, but also the sex of sex partners. So the plurality of the cases, almost 50%, 47.7% of primary and secondary syphilis were among men who have sex with men. And what we saw between 2019 and 2020 is that while men who have an unknown sex of sex partners in this sort of light blue, and men who have sex with women were kind of the second greatest number of cases, in 2019 to 2020, we saw an increase among women, such that now women make up the second largest number of cases of primary and secondary syphilis in the United States. And if we looked at that kind of in a breakdown for 2022, what we see is that women represent about 25% of the new cases of primary and secondary syphilis. Men who have sex with women, about 23%, and men who have sex with men and women, 4.8%. So if we kind of add those up, that's about 52.2% of the cases. And the reason I sort of point this out in particular is because this has particularly relevance for congenital syphilis, right? Which is what we're looking at next. And so as a consequence, we've seen a dramatic rise in congenital syphilis from 2013 to 2022. In 2022, there were 3,755 cases of congenital syphilis. In 2013, there were only 355, so a tenfold increase. And just in 2021 to 2022, the number of cases of congenital syphilis increased by about 31%. And that increase was concurrent with the rise, represented in this black line here, of primary and secondary syphilis, a 17.2% rise in the rate of primary and secondary syphilis among women assigned people assigned female at birth, age 15 to 44 years of age. So then I know we went through the epi pretty quickly, but I want to kind of spend the time to focus on kind of the intersections now. And so in contrast to the HIV data from the CDC, the syphilis and STI data gets a bit more granular around particular behaviors, specifically around substance use. And so it gives us an opportunity to kind of look at that intersection on a national level, and we'll kind of dig into it a little bit more in a little bit more of a detailed way as well. So in 2022, 11.8% of primary and secondary syphilis, or people diagnosed with primary and secondary syphilis, reported methamphetamine use, compared to 7% who reported injection drug use. And the other drugs that are measured here are cocaine, which was about 4%, heroin use about 2.2%, and crack use 1.5%. And really the only kind of increase we see is among the report of injection drug use, increased from 5.1% in 2018 to 7% in 2022, with sort of stable reporting of methamphetamine use, although with an increase from 2020 to 2021. The other behaviors that we can look at, and the one that I'm kind of specifically zeroing in on, is the sex while intoxicated or high. So 35% of people diagnosed with primary and secondary syphilis in 2022 reported sex while intoxicated or high. The other behaviors here: sex with an anonymous partner, 43%, sex with someone who injects drugs, 8.7%, and 5.4% reported exchange sex, so sex for drugs or money. So if we look again sort of more granularly at sort of both sex assigned at birth and sex of sex partners, we see some differences across. So for sex while intoxicated or high, among women diagnosed with primary and secondary syphilis, just under 40% reported sex while intoxicated or high, whereas 41% of men who have sex with women and 30% of men who have sex with men. And then in contrast, sort of women make up the greatest or more likely to report methamphetamine use or injection drug use, whereas men who have sex with women sort of a bit less likely, 15% at 8%, and then men who have sex with men least likely, 7.3% methamphetamine use and 3.5% for injection drug use. So there are lots of different reasons why people use drugs, and particularly use drugs like either connected to sex or not. But I did want to kind of bring out something that around sexualized drug use. And so if you ask someone in Europe, they'll call it chemsex. In the United States, it's more often called party and play. There are lots and lots of different names for it. But what it does is it refers to drug use before or during sex. And it can be used to enhance the sexual experience, expand one's sexual boundaries, increase connection, intimacy, increase sexual confidence and energy. Some people do it because there are, thoughts and feelings that come up during sex, or to cope with negative experiences, or trauma. Outside of Europe, data is pretty sparse, especially among women. And represented in the data, the communities most impacted include gay, bisexual, and other men who have sex with men, as well as sex workers. But I think this is maybe perhaps a more common practice than we recognize, and that is represented in the literature. So, and a variety of different substances are used during sex. We can think about alcohol, weed, cocaine, but the ones that kind of typically get lumped into this group of sexualized drug use, the most common one being crystal methamphetamine, but other ones sort of are represented, and it kind of differs in different subcultures and communities, but also represented here is gamma hydroxybutyrate, or GHB, alkyl nitrates or poppers, ketamine, MDMA, and mephedrone. Mephedrone is, I don't think it's super accessible in the United States, but it is something that is fairly common in Europe. And for GHB, people describe it as sort of like being drunk without the alcohol or the hangover, but it has a really narrow therapeutic window, recreational window, in that you have to be very careful with how you dose it. Ketamine provides sort of a calm, relaxed, maybe a detached feeling, sometimes provides some hallucinations or a dreamlike state. MDMA, feelings of closeness, intimacy, euphoria. And then mephedrone, people, say it combines the euphoria and the empathicness of MDMA, but with the energy of methamphetamine. And I neglected to talk about poppers, but those are sort of an inhaled, sort of a video, used to be used as a video head cleaner, that is helps with smooth muscle relaxation, and also kind of gives a sort of high woozy feeling. So these drugs can be used in a lot of different ways. They can be used by injection or slamming, which is sort of the fastest onset, most intense effect. Of course, thinking about injection-related risks. Smoking, also quick onset, and then thinking about, reusing smoking supplies. Burns are kind of common because things get hot. Snorting, more gradual effect compared to slamming and smoking, used more for ketamine and cocaine more so than crystal. And then there's just ingestion, GHB, mephedrone. And for those two, keeping track of timing and dosing is pretty important. Nasal insufflation, just breathing it in, sorry, fancy term, so poppers. Important not to drink those. They can also burn the skin as well. And then finally, this is perectum or booty bumping. It's a gradual but sustained absorption through mucosal capillaries that may lead to, potentially lead to overdose and overamping depending on how much one uses. But it is just more of a gradual increase, but it can still lead to sort of an intense effect. And it's important to kind of think about, some harm reduction strategies around sexualized drug use, setting and discussing personal guidelines and boundaries before use is important. Sort of noting timing, sort of being like, I'm going to just do this much or use this dose on this occasion. Using test doses, avoiding using multiple substances. Of course, using clean works and syringes if injection is the route of preference. Making sure that there are times, set breaks for eating and hydration. And then thinking about how it's going to impact, sort of the rest of one's work week, perhaps. And then also thinking about, health-related stuff, about your sexual networks, making time for medical checkups, regular HIV, STI testing, since we're kind of in that mix with this talk, and working in sort of taking PrEP, HIV meds, doxypep, and oral health is always important. So the reason I kind of bring this up is it's not something that's very much talked about, but also sexualized drug use does have associations with STI, hepatitis C, and HIV acquisition. So there was a meta-analysis of 19 English language studies from Europe and North America that found that sexualized drug use, which is sort of it's a grouped term, and it kind of incorporates all of those different drugs that I had mentioned. So there's a lot of variability and heterogeneity in this analysis. But they showed that there was, in terms of an adjusted odds ratio, an increased odds of contracting a bacterial STI, so gonorrhea, chlamydia, or syphilis, hepatitis C, and HIV, although the HIV confidence interval wasn't exactly statistically significant, but it's fairly close in terms of the lower bound at 0.96. And one of the things to keep in mind is that methamphetamine use is sort of consistently associated with not really sticking to an HIV treatment plan and lower rates of viral suppression. But when we think about how that chemsex or sexualized drug use might affect PrEP adherence, the data are kind of mixed. And there's not a consistent association of sort of a lack of sticking with a PrEP routine. You might think about, okay, so how do these pathways kind of work? So again, we know that sexualized drug use may lead to changes in decision making, disinhibition, condomless anal sex, and then this is STI and bloodborne illness, or HIV or hepatitis C. But also there might be some physiologic effects in terms of the changes in the mucosa, libido, energy. Using drugs with sex may also influence the sexual networks that one sort of operates in and has sex in. But also both are connected to and related to what we call syndemic drivers, so things like stigma, isolation, shame. The other thing that might kind of come up is also kind of working in one's sort of healthcare routine or healthy behaviors, like for those folks who are living with HIV, taking their ART, taking their PrEP, or most recently kind of thinking about doxy-PEP for STI prevention, as well as sort of working in healthcare visits as well. So kind of moving off of substance use for right now, and thinking about other psychiatric or behavioral health disorders, there's not a ton of data on this in terms of looking at kind of the estimates of risk around HIV, STI by particular behavioral health disorders. But there is a group, and they've published 4 papers now in Taiwan that they have a national registry. And so they're able to kind of look at folks with particular diagnoses, specifically mental health diagnoses and outcomes. And have been over the past several years sort of producing these hazard ratios, connecting or associations between depression, schizophrenia, bipolar depression, and borderline personality disorder, and HIV, STI prevalence. And so what they found is that there are associations between each of these behavioral health conditions and HIV, STI. And again, it's sort of a grouped, like all HIV plus many STI diagnoses, including herpes and genital warts and gonorrhea and chlamydia and syphilis. So there's a number of diagnoses that are kind of part of this, but it gives us kind of a kind of a crude measure of the prevalence. They do break it out by specific infection as well, but for sort of simplicity, I kind of present these two. I present that composite measure. And there's what they looked at is the control group prevalence, right? So these are folks in the national registry who didn't have any of these diagnoses. And then they looked at the prevalence among those with the condition of interest. And what we see is the adjusted hazard ratio, so that link or the association, there's 1.5 increase times as likely, so people with depression are 1.5 times as likely to have HIV or an STI compared to those groups who don't have depression. That corresponding number is 2.35 for schizophrenia, 4.1 for bipolar depression, and almost 51 for borderline personality disorder. But what you can see is that 91% is made up of a lot of like what I call prevalent STIs, so things like genital herpes or genital warts. So that may be an overestimate of the true risk. What was sort of common themes throughout each of these analyses is that alcohol use disorder and substance use disorder increased the risk, and that STI acquisition was earlier among those with a mental health condition of interest compared to those without. And that for those with bipolar depression, the longer duration of medication use for bipolar depression actually reduced the risk over time. Now, kind of thinking about the flip side, right? So now looking at among people living with HIV in the United States, 34% experience depression. And that's by either symptoms or by diagnosis. So this is a study, it's called the Medical Monitoring Project. It's funded by the CDC. It's done by state and local health jurisdictions where they interview people living with HIV, usually through a phone interview, but sometimes through video or in person. And they do a PHQ-8, so they leave out the suicidality piece, and or they ask people, have they been diagnosed with depression? And so when they're looking at these data, this was very recently published, they found that 34% experienced depression, either by having an existing diagnosis or by symptoms in the PHQ-8. And so when we look at this, depression was greater among women, all comers, cis and trans, people experiencing poverty, houselessness, food insecurity, and unemployment, folks with recent and lifetime experiences of intimate partner violence or sexual violence, and also people who report greater discrimination in healthcare settings or who report greater HIV-related stigma. It makes sense. But I know this is a lot, I'll summarize this, but compare when they then looked at sort of HIV-related outcomes, comparing people with depression and no current symptoms to people with HIV who have, say, the first column is undiagnosed depression, Those folks with undiagnosed depression were less likely to have an ARV prescription, were less likely to take 100% of their medications in the last 30 days, less likely to have an undetectable viral load, have a prescription for an antidepressant, or receive services from a mental health professional. And on the flip side, we're more likely to miss some of their HIV care visits or report that they had an unmet need for services from a mental health professional. And then when we look at folks with symptomatic depression, they were less likely to, again, take 100% of their medication in the last 30 days, less likely to have an undetectable viral load, but more likely to miss care visits, have a prescription for an antidepressant, and also have an unmet need for services from a mental health professional. Now, these sort of diagnoses, they operate, of course, at the individual level, but they may also operate at the community level. We looked at a county level predictors of congenital syphilis in Oregon from 2013 to 2021. And we looked at a number of different factors like quality of life, thinking about mental health. These are the county health rankings, which is a very specific model of, ranking counties by sort of healthfulness on the community level. Health behaviors, food insecurity, methamphetamine overdose, things like social and economic factors, unemployment, poverty, income inequality, adverse childhood experiences, violent crime, and then the physical environment. And looking at the county level socioeconomic and behavioral health challenges, I kind of highlighted the specific behavioral health ones, average number of poor mental health days, the methamphetamine overdose rate, and the percent of the population with at least one adverse childhood experience. So, and then those that are in bold are kind of more of the socioeconomic challenges. So if we look at this, it's just sort of a plot looking at the predicted risk of congenital syphilis compared to the score. And so the risk of congenital syphilis was greater in counties with greater socioeconomic and behavioral health challenges. If we want to put some numbers to that, again, looking at measures of excess risk in EPI, sort of a risk ratio, that the if we sort of put a particular number to that, so pregnant people who are living in a county with greater socioeconomic and behavioral health challenges were 1.2 times as likely to have an infant with congenital syphilis compared to those who live in a county with a lower score. And if we took away that behavioral health challenge, if we reduced it from one level to the next level, we could reduce the percentage of congenital syphilis cases by 19%. That's what this population attributable fraction is. So the community level socioeconomic and behavioral challenges has an effect, as does on the individual level. We also kind of looked at things like people reporting injection drug use or corrections involvement, which were also statistically significantly associated with congenital syphilis among pregnant people with syphilis in Oregon. Okay, so then we're kind of rounding out the intersections here. I'd be remiss if I didn't mention sort of psychiatric presentations of syphilis, because they happen. So we're, we kind of think about they're probably rarer because people get treated quite early with syphilis. And while psychiatric and neurologic syphilis can happen at any time, there are some psychiatric presentations that we should just be aware of, things like cognitive impairment, personality changes, mood disorders, psychosis, and very rare syndromes, one in which a family member has been replaced by an identical imposter, or hyperreligiosity and the need to draw or write. So, so I just wanted to kind of throw that out there to be sort of well-rounded in this. Okay, so then we've kind of talked a lot about some intersections. I know it could probably, there's a lot of different associations there, but I wanted to also then sort of like, let's ground this in some of the screening. And so to make things fairly simple is that For HIV and hepatitis C, everyone should be screened at least once in their lifetime, universally, regardless of risk. Okay. The other, and so that's what kind of this summarizes here. These are from the United States Preventive Services Task Force. They're all grade A or grade B recommendations, which also means they need to be covered by Medicaid, and therefore private insurance companies follow suit and cover them as well. And I have links to the full reports there. The other thing that's fairly new that hasn't been published just yet, but is that hepatitis B screening is also universal. It used to not be universal, but it is now also a universal screening recommendation such that people should be screened for HIV, hepatitis B, and hepatitis C universally at least once in their lifetimes. Now, when we look at syphilis, and we're going to talk a little bit more about when people should be rescreened or people who should be screened more often than just once. We'll start by looking at the syphilis screening recommendations. So they're not kind of up to speed with syphilis just yet, and not keeping pace with what's sort of happening on the ground, which is that it's increasing. So they say screen adolescents and adults who've ever been sexually active or are at increased risk. And the indications for screening include people who identify as gay, bisexual, and other men who have sex with men, people living with HIV, young adults, folks who've been involved in the carceral system, people who trade sex, people who use substances like methamphetamine, folks who have prior STI, unstable housing, and may have a high community prevalence of STI. The optimal timing isn't specified, and with the exception of gay, bisexual, or other men who have sex with men, and people living with HIV, in which they recommend annual or more frequent testing. So that's the sort of national screening recommendation. So it's not a universal recommendation like the others, hepatitis and HIV, but I think it should be. So I do think we should sort of follow suit that all sexually active individuals less than or equal to 45 years of age should be screened at least once for syphilis, if not since the very large increase in syphilis occurring really between 2020 and 2021. And I'm going to leave this sort of more for reference. I think those indications for annual or more frequent testing can be sort of fleshed out, thinking about things on the individual level, what partners bring to the table, because sometimes that's all people know, or they actually don't know what the partner brings to the table, but that's where the risk may be coming from. But also thinking about community and clinic level indications, like where someone's getting care, like a correctional facility or an emergency department, or a substance use disorder treatment facility, where the probability of or the risk that one brings to the situation coming into these particular clinics is just higher. The other thing to think about too, thinking about congenital syphilis, is that syphilis screening in pregnancy has been getting sort of revamped as well. And while a lot of local health jurisdictions, state health jurisdictions have been advocating for universal screening regardless of risk at 3 times during pregnancy, the first national organization to follow suit and say the same thing wasn't until April of this year, and it's the American College of Obstetricians and Gynecologists, which is great because I think folks are now like, okay, yes, we're going to do this. But I think it's important to know that folks who are pregnant should be screened regardless of risk at 3 times during pregnancy, their first presentation of prenatal care early in their 3rd trimester, and then at delivery. The other thing to that we've been promulgating is that every visit for a pregnant person is a prenatal visit, right? So screen pregnant patients with no limited or unknown prenatal care when they present to emergency departments or urgent care clinics, carceral settings, substance use disorder treatment or drug user health programs, or OB triage, where folks, and then screening for infections that may co-occur with syphilis, including HIV, hepatitis B, and hepatitis C. So to kind of round out some things here about how to incorporate some of this work or incorporate this into some of your work, is that HIV and STI prevention, it's an important part of sexuality, but it's also a small part of sexuality. So kind of there's a balance here because I think what is also part of the equation, not only the sexual health where perhaps the HIV, STI, hepatitis prevention comes in, but also things like sexual pleasure, right? The physical and or psychological satisfaction and enjoyment derived from shared or solitary erotic experiences, including thoughts, fantasies, dreams, emotions, and feelings, as well as something called sexual justice, right? Promoting sexual pleasure in law and policy as a fundamental part of sexual well-being, which is grounded in the principles of sexual rights as human rights. And then the final concept of sexual well-being. Sexual well-being sort of encompassing all sorts of things, but things like safety, respect, self-esteem, resilience, forgiveness of past sexual experience, comfort with one's sexuality, and then self-determination in one's sexual life. So it kind of behooves us to kind of really get comfortable talking about sex and sexual practices, avoiding stigmatizing language, avoiding being vague or using euphemism, but also asking our patients to do the same when sort of hanging out with or talking to, means something different. Countering misinformation when it comes up, listening to patients tell you about their experiences without kind of giving opinions or judgment, finding a balance between humor and seriousness, really contextualizing and being curious, but also just constantly learning. And there's a really nice, it's not necessarily for medical providers necessarily, it's really for sex educators. It's called the pleasure principles. And it's, and the sort of the kernel, it provides sort of guidelines around kind of talking to clients or educating folks around sex and sex education. But the central approach is kind of be positive, right? And by that, they mean taking a sex positive approach. So, and a sex positive approach aims to improve the quality of sexual relationships, promote empowerment in consensual sexual interactions, right? It's about an attitude that celebrates sexuality as a part of life that enhances one's happiness, right? It's inclusive of and celebrates all bodies, genders, sexualities, and practices, affirms the freedom of sexual expression, bodily autonomy, sexual consent, integrity, and privacy, and it's trauma-informed and aims and tries to facilitate healing from prior trauma. And in practice, kind of, again, we're ultimately trying to kind of think about, HIV, STI testing, prevention, bring up, but as we, that can be one way to kind of uncover some of that information that allows us to then make a plan for these things. So of course, asking permission to talk about sex with someone, creating an environment where it's safe to do that, and choosing a good moment. It's not always the right time. If you're dealing with something more urgent, maybe that's not the time to do it. But also kind of being like, hey, did you look, did you hear about this research? Or I just read some paper about how sexual well-being improves, X, that reduces the risk of heart disease, right? There are all these great things that sex can do for us. So, and then also asking about ideal experiences and leading with pleasure over risk. The other thing too is that sometimes it's important, and y'all may have some experience with this already, like of talking to patients about what it means to give consent or receive consent, right? What it means, to, when you're with someone, like they're a person, right? It's just not just a body, and that, there's an exchange of pleasure. Again, sort of with the consent thing, never assuming that the answer is yes, but always asking first and accepting always when it's no. Being able to tell the person what you like and don't like, right? That communication, and then really try to find a balance between kind of that lust, the humor, the seriousness, and the sensuality of it all. And sometimes we all need to be reminded of this. And when we're working with clients and patients, sometimes this comes up, and it's important to kind of say, hey, that we should talk about these things. And then what you do is once you've had that conversation, and I think 9 times out of 10 with these conversations, things are going to come up that are going to allow you to say, hey, it might be time for an HIV test, or hey, can I recommend, you talk to someone about pre-exposure prophylaxis? Or it also, may be thinking about pregnancy prevention. It may be counseling. It may be safety planning, right? So there are a lot of other things that might be coming up during these conversations that when we're listening and reflecting back, we can use to help people create a plan around their sexual health, specifically around, of course, HIV, STIs, hepatitis, because that's kind of what we're sort of thinking about in this sort of syndemic sense. But when we're working with our clients with mental health conditions or behavioral health disorders or substance use disorders, these things, we can do all these things. So I want to kind of finish before we, I'm running a little short on time, but is I also want to just make a plug for your local public health departments, probably because I work for one and I worked for one for quite a long time. But these are another resource for you when you have a patient who might need screening or treatment. Perhaps you're not doing the screening or the treatment yourself, but you might need, support, someone to be able to refer to, or when you need to, when you just need to want to chat with someone about what the best next step is. So public health departments can, their goal oftentimes is to interview folks who are newly diagnosed. Priorities are HIV and syphilis these days, but also gonorrhea, sometimes chlamydia, and also help people get their treatment and appropriate follow-up, but also help people notify their partners and get partners treated and tested and all that good stuff. But they can also provide consultation on HIV and syphilis. They can provide some advice. They can arrange for follow-up for patients and their partners. Sometimes if your public health department has a clinic, they can get people into the clinic, or sometimes they're able to treat people, quote unquote, in the field. So somewhere outside of a clinic. If you're wondering if, you're seeing a patient who said, oh, I just got this test result back and I don't know what it means. And, maybe it's for syphilis and you need to get records from other jurisdictions, they can help with that. Some health departments are able to provide incentives to patients and partners for follow-up visits, testing and treatment. And sometimes can address some special needs like housing during treatment, especially for things like syphilis or a new HIV diagnosis. And then finally, when you have a patient who needs HIV treatment or PEP or PrEP or doxy-PEP, right after the conversations about sex, these things come up. They can also help with linkage and relinkage to HIV care. Some may be able to rapidly restart or start medications, provide navigation services for, again, HIV care, but also for post-exposure prophylaxis, pre-exposure prophylaxis, and doxy-PEP for STI prevention. And get you in touch with, or patients in touch with, clients in touch with knowledgeable providers. Again, incentives can be part of that, and assistance with some social determinants of health like transportation, again, housing, food sometimes. So I just want to make a plug for your public health departments. And then finally, just to summarize kind of what we talked about. Okay, so we're not meeting the goals to end the HIV epidemic in the United States. We've made some progress, but not the amount of progress that I think we set out to do. Got a work to do. Syphilis continues to increase in the United States, particularly among women and infants. And there are lots and lots of connections between HIV, syphilis, substance use, and other behavioral health conditions. And so talking with patients about sex using a sex-positive framework may help elucidate a client's needs for HIV, STI testing, prevention, and treatment, all while leading with how sex is an affirming human experience. And then public health can support your patients in accessing testing, prevention, and treatment. Thank you. I think that's all I've got, and I'm happy to have a conversation, answer questions. Thanks so much for your attention.
Hi, Tim. Thank you so much. I'm wondering, can you hear me okay?
And yeah.
Perfect. Thank you. We do have a couple questions here. First one is, what is the risk of transmission from mother to child with syphilis? And is there treatment to stop or lessen the transmission?
Okay, great question. Yeah, so it depends on a couple different things. So it depends on the stage of infection. So if the primary and secondary, those symptomatic stages are more likely to be transmitted than the asymptomatic stages. And it depends on the timing during pregnancy as well. So earlier is a bit riskier than later in pregnancy. So if penicillin did not exist, about 80% of infants would be affected if the pregnant person had primary or secondary syphilis early in pregnancy. For those later stages and later in pregnancy, it's about 23%. But penicillin is very effective. It's 98% effective in preventing congenital syphilis. So treatment of the pregnant person will treat both the pregnant person and the fetus at the same time, reducing the risk by 98% for congenital syphilis.
Wow, that's great. Thank you.
Yeah.
Any suggestions or examples of successes with supporting the reduction of STIs in unhoused populations? What would you recommend for sex worker harm reduction? Or they're asking, would you recommend safer sex kits?
Yeah. I think there's a lot of ways to think about this. So for unhoused folks and people who use drugs, I think one of the things that we've been trying to do here in King County and Seattle is taking testing, basically bringing testing to people rather than asking people to come in to a particular place or a clinic. So that's one way, especially for unhoused folks. For people who use drugs, and I mean, there's crossover there. The other thing that we've been trying to ramp up more is offering testing in our syringe service programs. Now, I know injection is sort of less common and smoking is more common, but our syringe service programs have now started providing smoking supplies, and so have gotten more, we had this sort of lull in attendance at syringe service programs, and so folks are now coming back. And so that means that, we can implement testing that way. And so that's a big piece of the puzzle. I think the other thing too is around sort of the expansion of pre-exposure prophylaxis. Partly because, the marketing was largely around gay and bisexual men who have sex with men, and really initially didn't include people who use drugs, didn't include cisgender women. And so I think we're kind of now starting to focus on and see the value of PrEP among people who use drugs, people who inject drugs, and really trying to also push PrEP and things among sex workers as well. And so the other successes we've had here with sex workers specifically is doing sort of mobile clinics where folks generally work. And they've seen some success with people coming in, starting PrEP. They've even done some prenatal care there. They also offer Suboxone and medications for opioid use disorder, and then also provide, of course, condoms, lube, safer injection supplies, that sort of thing as well. I think one of the things that is another sort of question, and we're thinking about, is doxy-PEP, or using doxycycline for post-exposure prophylaxis. So taking 200 milligrams of doxycycline within 24 to 72 hours after sex to prevent syphilis or chlamydia. It's really been studied among people assigned male at birth who have oral and anal sex. But there are plenty of people who are not assigned male at birth who have oral and anal sex with people with penises who may be at risk and could use doxy-PEP regardless of their gender identity. So thinking about where that fits in, especially for sex workers, is something we're kind of actively wrestling with right now. Thanks for that question.
Yeah, Tim, I'll just chime in to thank you also for a great presentation. This is really interesting information. It's alarming information, and it's really helpful, and will give people an opportunity to chat in a couple of more questions if they have them. But I was just sort of thinking, along the lines of the first question about just the really alarming rates of syphilis and congenital syphilis, and your statement that every visit of a pregnant person is a prenatal visit. And thinking that, that includes us with our behavioral health visits, when people come to see us, and just trying to think about, do you have specific, and maybe not recommendations, but recommended resources? Like the toolkit is a great kind of talking about sex and sort of coaching providers about how to be more comfortable of what kinds of questions to ask. But then how do we link that conversation to assessing risk and somebody who needs syphilis testing? Is there, I think what we hear from our providers is that it would be helpful to have very concrete and specific guidelines. These are the people you should think about for PrEP. You should think about for syphilis testing. And where should we look for those?
I think the one resource that I found that is both sort of provider friendly and patient friendly and client friendly is the March of Dimes information on congenital syphilis. It's general, it's specific, but also has the sort of the recommendations that I think are helpful. It also speaks in just sort of plain language around what congenital syphilis is, what it means, how it can be treated. So there's that particular resource that it's like sort of substantive and can be a resource for both clients and providers alike. Of course, the ACOG guidelines and public health guidelines around screening and just how knowing that pregnant people, if just sort of checking in with, because on the flip side of Kate's question, the flip side of Kate's question is that, yes, there's this medication to prevent syphilis, right? And prevent congenital syphilis, and it's very effective. But what we see is that folks don't necessarily attend prenatal care visits. They may access other touch points with a healthcare system, right? Like they may access sort of a food bank or a WIC or a shelter or a behavioral health or substance use disorder treatment, but they're not necessarily accessing prenatal care where that screening might happen. And so they may present at delivery and get diagnosed, and then there was no chance to prevent that infection. So in King County, at least, and I can speak a little bit to Oregon, is that about 67% of pregnant people who are associated with a case of congenital syphilis, they didn't have any prenatal care during their pregnancy. In Oregon, it was more like 30 to 40% statewide. And what we had found in Oregon is when we started to ask people, okay, so you didn't go to prenatal care, but where did you go? Peer support groups was one of them. Food banks was one of them. Shelters were another. Sometimes visiting nurses were another. So if folks who are coming in are pregnant, sort of perhaps asking about how their prenatal care is going, are they going to prenatal care? And also the screening piece of things. Hey, are you up to date on all the screenings? Did you get your blood tests? Hey, did they redo syphilis screening? And I found out this new recommendation about syphilis screening in the third trimester now. Like everybody's supposed to have it. Perhaps kind of just sort of being that supportive person, during that pregnancy as well, as you're supporting their needs in other ways. But maybe that sort of check-in, because sometimes I feel like there are some folks who are like the only touch point for some of our pregnant folks with syphilis, partly because when we think about the syndemic piece of things, of housing, of substance use, of histories of incarceration, the risk of presenting to a medical provider where they might get reported to DHS for their substance use, or in some places they can be reported to law enforcement, right? And there's that legacy here in the United States that just makes the stakes really high for people. So if you are a touch point for someone like that, it's like so critical. Yeah.
Thank you, Tim. Thank you, Lydia. Was there more? We have a couple of questions too in the Q&A.
Yeah, go ahead with the Q&A.
Okay.
Yeah.
No problem. Somebody had asked, asked that many facilities do have sexual health questions and are, which may not be trauma informed or inclusive. Do you have any recommendations?
Yeah, I can, it's kind of the norm. I think so I will, let me first say that in a lot of ways, those questions, right, probably were made like 5 to 10 years ago. They're like sort of requirements for grant funding. And so they're like, just like a thing that people they have to ask, right? So there's that. Doesn't make excuses for them, right? So I don't want to, but there are some questions I can provide. There's two. I actually gave a talk that had some similar, not the same, but similar content around like questions one can ask with a more sort of sex positive valence. So I'm happy to share those. The other, there's something called the GOALS framework, GOALS framework, which is put out by the New York State. They have a, I'm trying to remember they basically have sort of an HIV sexual health education program. And I'm happy to find the link and everything. They also have sort of a series of questions that you can ask that aren't sort of the, how many partners have you had in this amount of time and what kind of sex you have, and don't pay attention to like, anatomy and gender and all the things that, are important to people that really get kind of lost in some of those questions. So happy to share those resources for sure.
Great, thank you. And last question in there is about PrEP for STD. What is that, and what is the risk or side effects?
Yeah, great question. So this is a fairly recent development. And so the CDC just released their guidelines, and it's called doxy-PEP. So doxy standing for doxycycline, the antibiotic, and PEP. Peyton, you were so good. So the goals framework is in the chat. It's so good. The goals framework is in the chat. So doxy-PEP. So doxycycline is the first part. So antibiotic. And then PEP, post-exposure prophylaxis. There is also pre-exposure prophylaxis. So taking pre-exposure prophylaxis, meaning sort of just like HIV PrEP, taking it every day before exposure to prevent infection. And that's also being studied. But what's been studied on a couple different studies at this point is taking a dose of doxycycline after sex as soon as possible, but within 72 hours, so about 3 days. And what they showed is that it reduces the chances of acquiring gonorrhea, syphilis, or chlamydia by about 65%. Again, studied among people assigned male at birth who have sex with people with penises, oral and anal sex. And more specifically, they really are cisgender men who have sex with men and transgender women who have sex with men. And so it's now kind of in the sphere of STI prevention. The recommendations are that it's for people who have been diagnosed with an STI within the past year, or who have multiple partners, or anticipate having multiple partners in the future, right? And so those are kind of the guidelines that are out there from sort of CDC and most local health departments. And so with that, there's been sort of a push, I know largely in major cities, to kind of implement this as an STI prevention tool. And as a result, there's been some data, or there have been data from Seattle and San Francisco showing that there's about a 50% reduction in syphilis over the time after implementation of syphilis, specifically among men who have sex with men. And with stable levels, as you might imagine, among women or men who have sex with women, because those folks are not the eligible population. However, there's a lot of interest, especially with congenital syphilis and syphilis among women and people who can become pregnant, and pregnant people in doxycycline as a syphilis prevention tool. Now, you also asked what the side effects were. So in general, a little bit of stomach upset. We generally ask people to take it with food or a big glass of water, or be upright for 30 minutes before sort of going to bed. If they take it right before bed, can sometimes irritate the esophagus. The other things, it can sometimes make people a little sun sensitive. The thing about taking antibiotics too is that we have good bacteria, right, in our throats, on our skin, in our GI tracts. And so we're not really sure about what that's going to do over the long term. And then finally, we sort of do know, we don't know if it was spurred by the use of doxycycline, we don't think so. But gonorrhea, it's not as effective against gonorrhea these days, because gonorrhea has already acquired resistance to doxycycline and other antibiotics in that class. So while we'll probably see reductions in syphilis and chlamydia, we may not see a big effect on gonorrhea. So yeah, thanks for that question.
And kind of following up, are there any upcoming advancements in take-home tests for STIs?
Good question. So yeah, you know, the oral fluids HIV test is still the only FDA approved test for home use. That's been around for a long time. It's been sort of reinvigorated in its use in a project that was initially called Take Me Home, takemehome.org, which is now called Together Take Me Home, which is now run by the CDC and funded nationally, which is basically a free mail order HIV testing program. So if you order a test, you get one of these oral fluid, or you can do a finger stick too if you're adventurous, oral fluids HIV tests mailed to your home discreetly, so that you can do in the privacy and comfort of one's own home. And that's kind of gotten expanded, so it's nationwide. Now for STI specifically, there are a couple different organizations. There's a few different labs. There's a Johns Hopkins lab and they have something called I Want the Kit. And they've just actually also indigenized it. So for tribal communities, they now have a specific I Want the Kit sort of marketed and branded for indigenous folks. And that's, I think, going to be live nationwide pretty soon here. They're working with the Northwest Portland Area Indian Health Board and I think the Great Plains tribe as well, to get that out there. And what it entails, as I understand it, and there are other versions of these home testing kits, are swabs, both for the throat, the rectum, and urine collection for gonorrhea, chlamydia, and I believe they include trichomonas in that. And then something called a dried blood spot. So you poke your finger and you put a fairly good amount of blood onto what's called it's called a dried blood spot. It's called this protein saver paper. So it's what we do for newborn screens, if you've ever seen one of those. So you put the blood there and then that dries, and then you send those things back to the lab, and then the lab runs those tests, and then you get kind of results through like an online portal. And so there's the Johns Hopkins I Want the Kit and the indigenous I Want the Kit. There's also molecular testing labs, which is in Vancouver, Washington, a place called Let's Get Checked in LA. And then there's a new one that the name is escaping me right now, but they kind of all use a similar platform. So there hasn't been real kind of advances in the tech per se, but just the fact that there's a proliferation of opportunity for these home test kits. Depending on where you are in the United States, there are some states and jurisdictions, Oregon was one of them, where we also implemented not only the oral fluids HIV screening, we also implemented home testing, home STI testing as well. So there your state may also offer that, which is a great resource for clients. But the CDC thing is called Together Take Me Home. I think it's Together Take Me Home. It might even be takemehome.org still, and it just routes you to the national program. But it's a great it's a great program, and it's free, and it's sort of reinvigorated this sort of like this home testing revolution is what the progenitor organization kind of called it, which is really fun.
There's hope. This is promising, definitely.
Yeah.
Like you said, as long as the tech side kind of catches up. Yeah.
Right. And there should be no wrong door for testing. I think it should be you should be able to just turn your head and get it, but that's my vision.
Yeah. And for those in attendance still, I don't have any more questions in the Q&A box. I'm wondering if any of our panelists here have any questions or anything they would like to say.
I think there was a raised hand. I think it was actually Mayumi who had asked the question about the advancements.
Yeah.
I don't know, Mayumi, if you want to. I don't know if we can unmute.
I saw that, and then they put the hand down and did the clapping. So sometimes we get confused with the hand up and
too
the
many
emojis.
options. Yeah. No, this was fantastic, Tim. It's just so much information, and we really appreciate the resources. Great questions. We've had a really great, this is actually our final session for the webinar series. It's been a great partnership with the AETC, and it really is just some foundational information for our behavioral health providers and organizations. So we'll definitely would encourage people to complete the evaluation. We'll take a look at what you all have said from these sessions and try to come up with AETC will try to come up with some more programming and really just support this really important work.
Thank you. Thanks for having me.
Yeah, great. Thanks so much. Thanks everyone.
I'll share my screen now too with the QR code. Sorry.
Yeah, appreciate everybody taking your time and being with us today.
Thank you. Absolutely. Tim, thank you so much. This was
of course.
So much information. Absolutely. Swimming in it. Loved it.
No, I know I felt a lot. It felt like a lot to me. So I'm sorry.
Well, and thanks for the reminders about our colleagues in public health. I think those are our great allies and just waiting to be helpful. So a good reminder to all of us. So
for sure.
So thanks again for joining us. Please fill out the evaluation, everyone, and thank you for taking the time to join us. And the recording will be available, including all of the resources, helpful resources that Tim shared.
Great. Thanks so much.
Thanks, everybody.
Yes. Thanks, everybody.